our speaker, Professor Ali Asgary, who is a professor at York University, and then Professor Ali is an associate professor of disaster and emergency management at York University. He's also an executive director of York University Advanced Disaster Emergency and Rapid Response Simulation. His research focuses on simulation, modeling, geomatics, artificial intelligence, and virtual and augmented reality applications in disaster and emergency management, disaster recovery, and business continuity. Dr. Asgary is a member of FAC, which is the Public Health Agency of Canada, external modeling group, and serves as the principal investigator or co-principal investigator of several research projects, including some COVID-19 projects funded by the Public Health Agency of Canada, which is the FAC, University Health Network, Canadian Institute of Health Research, and Social Science and Humanities Research Council. I must add that the Advanced Disaster and Emergency Research Rapid Response Simulation unit at York University just came up with an app that will help in drive-through vaccination clinic. So Dr. Asgary, we are proud to have you at York. I'm proud to know you in person, and we are glad that you are here to share your work with the public. Welcome.
Thank you very much, Dr. Kong, and everyone else.
Ali, you can now share your screen because I stopped my...
Sure, I can.
Okay. Thank you.
Thank you. You see my screen now?
Yeah, we can see your screen. Thank you.
All right. Thank you very much, everyone. First, let me thank you, everyone, for coming and joining us this morning. And of course, in some of your places may not be morning anytime. And also thank you, Dr. Kong and colleagues, for inviting our group to present one of our ongoing research projects to the team. When you asked me to do a presentation, among the works that we are doing, I decided to choose this one, mostly because it is an ongoing project and it is a challenging work. And I thought maybe sharing the methodology that we are working on maybe at some point also useful for other people, as well as for us in getting feedback and criticism, comments regarding this work. To us, this is this kind of work, at least I had not seen before. So in terms of the methodology that we are applying, or at least I would say in terms of setting and also in terms of the combination of methods that we are trying to apply. We see some promising results, but I'm sure there are lots of things ahead of us to make these kind of simulations and modeling matching the reality and helping us to better understand the situation. So within the time that I have, I would first like to introduce the group behind this work, and there are medical team groups from Dr. Shafi's group that is in this project, and from different institutions, but mostly from University Health Network, and also our group from York University, including professor that you know them very well, as well as our postdoc like Mohammed and Mahdi, and our graduate student Nazanin, who is working with us on this project. I really appreciate their hard work during this period. We have had a lot of meetings, continuous meeting and discussions and exchange of information. It was amazing just to have this group of people working together in this way. We also would like to thank a number of agencies that are supporting this kind of research, especially University Health Network, and Public Health Agency of Canada, CIHR, Ontario Research Fund, which is the main reason for ADER-SIM existence. And so we really appreciate their contribution to this research. What I'm going to try to cover this morning are lined out here. And I hope within the time that I have, I can go through them briefly. And the idea, as I said, is to really provide you with an overall understanding of our methodology and get your feedback. Providing the details may need extra time, and we have already drafted a manuscript for this, but still working on finalizing it, so it's not yet, but it will be hopefully presented somewhere soon. So first, I will give you some background about the context that we are talking about, which is, of course, dialysis patients and dialysis units settings. And then explain a little bit about how we created our 2D, 3D model of the setting, which was used as a base for our simulation. And briefly explain some of the processes we applied into our simulation for different agents that we have in our model. And also show you a brief clip of the model in runtime. If Zoom permits us going through this. And then I will explain the result of our first component of the model, that is a contact generating matrix that is presented soon after. And then the last part, that is how we use this contact matrix in another agent-based simulation to come up with disease modeling of the situation in this particular setting. Basically, I don't know how many people are familiar in the group familiar with this particular setting and situation, but I'll try my best to, based on the information that we have, to provide you with some background in case you are not specifically working in this area. Overall, there are about 14.5 million people with this kind of situations, kidney disease, that require dialysis or continuous dialysis, and which is quite a number if you include their healthcare providers as well as their families, communities, etc. In Canada, estimated to be about 40,000 people using this kind of services in a regular basis. This excludes Quebec. And in Ontario, we have around, these numbers changing dynamically because of what happens to these patients and situations, new patients coming in. But currently, it is estimated to be around 13,330 patients, and that are provided with services through 27 programs and 100 sites. So imagine there are 100 sites providing this service in Ontario only, across different cities and communities. And very briefly, about 95% of these people everywhere, almost, they are using dialysis services inside these units. So there's only 5% of them doing it at home. And for each of them, it takes, usually they take or have to do 3 to 5 times a day. Each time takes like 3 to 5 hours of operation. Since COVID started, there were lots of course, research reports coming in showing that this group of people are highly vulnerable, especially when it comes to death rate, because these people are already vulnerable, have underlying problems which when added to with COVID, the situation get worse, and so it grabbed attention by researchers and people in public health, in particular, to see and develop methods to minimize the impacts on these groups. In fact, studies or data at least shows that some of the initial patients died because of COVID in US and other places were those in dialysis services or using dialysis services. Around the world, there has been several outbreaks in dialysis units, and in communities related to them. In Wuhan, for example, when first started, there were a unit with 37 patients infected, and among the staff, also 4 staff, and 6 of those patients died. In United Kingdom, it was in earliest stage, about 9% of dialysis patients contracted the virus. In France, for example, evidence are that prevalence was about 6% for the first surge. In USA, seroprevalence was about 8%. These are based on studies conducted in some samples. And also in Spain, 20% of healthcare staff in nephrology departments were diagnosed to have. So it's a range of impacts on staff as well as patients. In Canada, there are some data. There's no, by the way, kind of comprehensive data available for these situations. All we have is, scattered information here and there. But this data that is available through Canadian Institute for Health Information, you can see that we also have had a large number of cases overall in Canada. About 620, for example, patients of this kind hospitalized, and in Ontario only we had about 408. These are from January to March, but of course numbers are much more now. And you also see the conditions or age, for example, conditions of this group, around 62 overall, and the number of people dead after getting COVID is in this data, for example, 8965. Moving faster, there are of course a lot of challenges related to COVID-19 for dialysis settings, in part because this is not a service that can be stopped like many other health services, such as, for example, elective surgeries, etc. This has to be provided. They cannot live without this service, so it has to be continued. And also, the fact is that in-center, what is called hemodialysis, also increases the infection transmission among both patients and healthcare providers and family members and community at large, whether they are infected or being infected at different settings. And the problem is that this kind of outbreaks, of course, impacts the staff, and shortages of staff is one of the issues of concern, because this is really highly professional service. It cannot be done by anyone. So finding and preparing this number of people to compensate for staff shortages is kind of difficult. And this also increases the waiting time for dialysis, meaning that when you are, have shortages of staff, they have to wait people to get this, and some of these people actually try to avoid some of their shifts, and the patients not to attend their shifts, so it also increases their risk for them. And the fact that also during COVID we noticed that, data shows that there were COVID patients without previous kidney problems that have experienced kidney problems, that some of these resources also need to be shared somehow between these groups. Another problem with COVID in this kind of setting is that these settings are complicated. This is implementation of some of the measures that we are talking about is not really as easy as maybe other settings in here, although they are trying their best, but really configuration or reconfiguration of these places is a bit difficult. There are a lot of space limitations. Some of these units already are full, working on full capacity. Scheduling of the patients and the staff is also a complicated, we found it, process. Also, most of these services require close contact, meaning that nurses, assistants, and others need to get close to the patients to provide the service. Not all of them, but most of them, especially because these patients need assistance, need help to even, you know, move sometimes and so on. So this close contact is an issue. And these patients are also highly exposed because they have to travel from their home to using public transit to hospitals, being in hospitals, going back. This makes them even more exposed to the situation. Also there are cases, again, based on studies, and my colleagues also talked about this possibility that some of these patients, because of the nature of their disease, may also show or be asymptomatic patient, COVID patient as well, because of the mixture. Now, briefly explaining the case we are working on. The case in hand that we use as our test bed or to develop this model is Toronto General Hospital Dialysis Unit. This has about 55 to 58 beds or rooms, beds for this kind of service. And it provides service currently to around 308 patients. And 50 out of these are what is called nighttime or night shift patients. The rest are coming in different day shifts. There are about 10 what is called most responsible physicians, and there are about 12 nephrologists and 110 nurses, 30 assistants, and housekeepers and clerks. As you can see, nurses and nurses in particular are the largest group of staff here. And after that, your assistant nurses, of course, do the most of the work with patients, and assistants are those who are preparing the machines, and housekeepers, those are doing cleaning, and clerks, some of them are helping, you know, in the receptions area with the patients, and nephrologists and most responsible or MRPs, they are providing physician clinical services to these patients when needed. There are some data that are showing there were some cases in this unit also among the patients, and so studying this in such detail requires and is important also. Before we start modeling this, we had to examine basically the existing floor plan to understand it and create our simulation based on that. This is the current. This is basically the floor plan of the hospital. This green part is what is called West unit. The rest are called East unit. Beds are, as you can see here, there are not walls in between all these. There are just some curtains. So these are like open space mostly. And there are offices and places for different services that I will explain. And these kind of pictures shows you, for example, this corridor is looking like this in reality. This is the entrance around here. And this is one of the existing, for example, stations for people. So we basically turned that floor plan into a 2D model for our simulation using AnyLogic software. This is the 2D look of the area that I'm using to explain some more details about different places. As you can see, for example, doctors, they have an office here. They don't stay here, they just come visit and they go often. Sometimes they don't stay here, but in case they need offices, they stay here. Nurses have several stations around this different in the west and east part. And as you can see, these are locations where nurses are working. Assistant stations are sometimes mixed with nurses, as you can see here. And you also have if they are staying, and housekeepers stations. One is here, for example, another one is here, and we have dialysis units. That is these chairs you can see here are dialysis. And this is a look of 3D model here. And in each, of course, there are other facilities like washrooms, lockers, etc. For example, in a daily basis, when patients, when staff come from here, mostly they go to their lockers, change, and then get into their services. We needed to basically build this model to see how this operation works in regular situations, and then add disease modeling into this. After we finished building the 2D, 3D model, we started working on the process part, which included our main agents. As you can see here, for each agent, we examined their process, working closely with the team members who were working on that facility and setting. And for each, as you can see from the beginning, when this is for patients, as patients enter the system, we develop their processes for them. They wait in the lobby, and then they wait for they are screened, and then they wait for the nurses to come and pick them. And as they go, they wait into their stations, and after that, nurse comes to connect them, and then after they finish, they wait for a while, and then when they finish, they are getting off the hook or these machines, and then go home. So this process continues based on the schedule of each patient every day, to whatever you want to run this model, based on number of days that the patient is coming, and days of the week that this patient, they have a special schedule that has been included in this. Same for clerk and housekeepers and etc. The same process. Whatever they do, we have modeled them here using this pedestrian, what is called process modeling inside AnyLogic. There are, of course, for each of these blocks, you have some codes attached to them. That is, I'm not showing them, but they are really detailed into what happens there. This is for assistants and nurses. Again, for example, nurses, they enter the hospital based on their shifts, and they get prepared to go to their locker room. They change, and then they get positioned in their places and do in kind of interval work with patients and until they finish their own shift. And this is for MRPs, or most responsible physicians and nephrologists. These are less complicated compared to the previous ones because they come to the unit and meet some of the patients if they need, and then they leave basically. And there are not many of them in the whole system. These are some of the information about the weekly schedule of healthcare providers and patients, just to give you some idea about what happens there in a weekly basis. For example, MRPs, as you can see, and I mentioned there are 10 of them that have a weekly schedule of 1 to 3 days. For example, an MRP may come only 1 day a week, and these are the things that makes our model really complicated. And some of them come in 3 days a week. And they also have different arrangement for different wards. Some of them go, for example, eastward, some of them westward, and some of them mixed. But we have assigned them randomly in this simulation. Nephrologists, almost the same. And nurses, as you can see, they come every day. A nurse, for example, comes every day, but on his or her own shift. And number of them per shift is about 10 to 25. And again, we randomly distribute them to their wards and also patients. Same with assistants, not taking time to explain in details, but this provides you with some understanding of what are behind some of these numbers and scheduling of these people. For patients, as you can see here, there are 308 patients. In fact, these are the range of service ranges from 3 to 6 times a week, meaning that one patient may actually visit the hospital 6 days a week. The only time that this unit or setting is closed is Sundays. It operates on Saturday as well. And the number in each shift is about 55, except the night shift. No, even the night shift is like, no, 30 for night shift. This is after we set those processes, model starts running, of course, but we added another engine to this that generates a lot of information about the contacts. For example, we can calculate the number of contacts based on these processes that we included there. We can calculate the contact time, meaning what was the contact period between for each of these contacts. And these are just example. And we can also calculate the distance that these agents have been during that contact. For example, 1 meter, 2 meters, we capture within 2 meters, but within 2 meters, we can say, for example, this contact and this contact was for example, 50 centimeters, and within that range, so that we know which one has closest contact versus the others. Although this has not been added into our calculation, I'll talk about this, but this is now generated as an output of the model. This chart basically shows how this contact calculation operates. We use a function called agent in range function. That for each agent, it considered that as index agent. It captures the number of agents or agents that are within that area of 2 meters. And depending on the time setting, which we also consider to be very important, we capture these contacts. For example, this is what I'm presenting here is based on seconds. We run every second and see who is within this range, who is not. And if they are within that range, that is counting that as to be a contact. And same, if that person leaves that area of that agent, then we discontinue calculating the contacts. And from the time that this person is within that range, we start counting the time for this, contact between these 2 individuals. Which means for every person in this system, at 1, for example, second interval, we are capturing these numbers. And then what we do then do the same for minutes, because it is important to compare these. Obviously, for example, there are more contacts when you are looking at it at each second, because some of the contacts last, for example, less than 1 minute. But we do also do this for 1 minute. We can calculate to whatever time frame we want. And that was the essence of the work. I mean, we don't want to say that we have to use this or that. This is something that we are now working on to find what is the best or what should be the best criteria in selecting those contacts from what we are generating. So what happens, I mean, then these are the parameters that we have in our contact or simulation for generating the contacts. Some of those that I mentioned before, I'm not repeating them because I know we want to have some time for question and answer. But basically, these are some of the parameters relating to, for example, the time frame for each of those activities and stuff that are used in this simulation. This is probably a short video just showing the 2D model in runtime. I just go on it very quickly so that you see what has been modeled and what it does. Of course, you can set some of the parameters in advance if you want, but the current setting is based on what is there right now, but this can be adjusted for because our goal was to see what would be, for example, the impacts of rescheduling, or if there are some shortages in the staff, what would be the impacts on the operation, etc. So as you can see here, this is the time is about 8, quarter to 8. This is running fast so that we can show you more. And we also have some coloring here just for the purpose of showing how this works when you, for example, have an infected patient coming into the system based on some of the parameters that we have. Actually, we have added, I exaggerated this here so that you can see visually, but this is not the real outcome. I mean, numbers that you can see here just based on adding some more just for visualization here. And so times goes on. There are shifts. For example, the first shift start from around 7:30, goes up to 12:30, and the next shift starts at 1 o'clock and then goes to about 6 or about 5, 6, and then the evening shift, then the night shift. So this captures almost. Now you can see here the patients are in their stations, and these people who are moving here and there are either patients trying to leave. This is about 12:30. Patients, some of them are started leaving their stations and moving out. And around 1, you will see that new shifts starts, and existing staff will leave, and some new staff will join and come to the center. So this is what you have when I said we are calculating the contacts and their, everything else. This is lunchtime almost in one of the runs when you are allowed to have or use that spot for lunch, for example. And so yeah, I just want to show you when the times goes to 1 o'clock and shift changes. And you will see some, yes, and new staff are coming, and some of the existing staff leaves, and new patients are also arriving at almost the same time as new staff are joining. So this is how it works, and this model runs for the whole week, because this is not a one-day thing. You need to consider that. And also, I briefly, as I explained, show you. So I show you the 3D model. This is important because we want to, because some of the works related to our models or our investigation requires, for example, some arrangement in the space that, especially when it comes to, for example, if we want to consider airborne transmission, etc., having the 3D model would help. And so that's why we have, although we are not using that in this presentation per se, but that's why we have this built. So I'm showing probably the same. Okay, sorry, I didn't go to the next one. I think this is the 3D model. I'm mindful of time. Just pressing this to go a little bit further. Yeah, just want to show you how it looks like in 3D model as it works. You see, for example, patients are in their stations, nurses are going around, physicians, etc. We haven't gone into too much detail, but as much detail as we found needed for this application. So I'm stopping this and moving to the results. So basically, this is some of the results. I mean, just a sample result of what this generates and what I have used also to show you some of the applications of this. This matrix here is between average daily contacts that has been calculated based on the total contacts that different agents had in this system and averaged on based on total number of those individuals in each. For example, here you see assistant with assistant 73. We have, for example, nurse with nurse 15. These are happening because some of these staff and people work together and are always close to each other, and whether they are in a station and sometimes even when they are work together. So you see, these are some of the results that we have been able to get from this simulation. This has to be validated by real world, but from what we see or what we expect, it looks to be reasonable, but we need to, we haven't done the validation because it's not basically possible for us. And this is one of the advantages of probably using this kind of simulation, to have some sort of estimations of these kind of contacts. And here, this matrix is average distance in contacts, for example. These are not necessarily for the same run and same period of run, but give you some indications. For example, assistant with housekeeper is 1.37 average distance in terms of contact. Usually they have like this 1.15 centimeter distance, but for some you see is lower, for some it is higher. And this one is average contact time between different agents for a day. And these are also in, I believe, seconds. So what we have done is that we have used, after we created this contact matrix, we have also developed a different agent-based simulation to use this contact matrix for, understanding the disease transmission or predict disease transmission in case of different scenarios. Here you see some of the components of that model. And by the way, I should briefly mention why I'm going to stop at 11:15 so that we have time for, and I'm almost done with the presentation. This model is, as you can see, a typical CR model, which captures, the process. This is for day, and the transmissions happens from different agents in this block when each agent is able to infect others, depending on whether they are asymptomatic or infectious or infectious pre-symptomatic. And we also, in this case, have hospitalizations and isolation, just like other models. Although really we care about this exposure in this context. And we also added a component for testing so that we can measure if there is a test, what would be the impact. Testing, random testing of patients, random testing of staff, what would be the overall impacts. And this state chart here captures the home and hospital type of relationship or situation, location of agents in this case. And we use some of these existing parameters. We don't say that these parameters are necessarily or should be necessarily used for every setting, but for now we have used them. These are some of the parameters we used for other models, and we included them here for just for the test. But I think we should be careful and maybe find some maybe other or at least check if some of these parameters are suitable for this context or not. And these are some of the results. I'll summarize with that. And you see, for example, if there is an asymptomatic patient coming to this system, based on that contact matrix that we are using and the model that we are using for the simulation of this is what we can observe for different for the overall group, which is this one for every people, including a staff and patient, and individual group of or agents. For example, this is for nurses maximum is about 30. For here is for clerks, that is really not much. These are not having direct contacts with others as much. And here is, for example, when we have an asymptomatic nurse scenario, what happens in these cases? Obviously, as you can see, we have higher numbers of contamination, mostly because, of course, nurses are more and also have more contacts with patients, and so overall, and others as well. So we have a lot of, and this is a sample result for our model when we implement testing that shows it helps. This is testing again with certain parameters in this test. I believe we are testing four patients in a daily basis, but randomly as they enter the unit. And this is going to be the impact. All other parameters are the same as the previous result that I showed you, which shows a significant reduction, or some reduction, I would say, in the overall contamination. And this is a table that summarizes these scenarios just for comparison reason. Again, you would see that under this particular experiment that we did, the number of contacts versus also in time of contacts, how they vary among different group of agents and between them, with and without testing, basically. So I think with this, I'm going to summarize some of the overall limitations that we found through this process and why we came to use this, and some of the future directions that we want to have. First, the reason we started to branch our main simulation from our disease model was that we found running the model in that complex and so many agents interacting in many different ways was very time consuming. Even running this agent-based model that we have for all these processes takes some hours to run for 1 week, but we really need to run this for many more times to be able to get some sort of to include the stochasticity here. So for that purpose, and the fact that for our disease model to be run, we definitely need much more number of runs. So we decided to generate the contact matrix from this model and then use that contact matrix to work with our disease part. That was the limitation, and also why we came up with this solution to that. As I said, these examples that I provided you with are some experiments, and we need to do more runs to get more, final results that includes like an average that is reliable. We also need to validate this against some of the real world situations, although we have some numbers based on what we have been provided to build this model in the first place, but as you can see, this needs more work. And transmission rates, what we have used, need to be recalculated or adjusted based on, because these are not necessarily based on these kind of settings and situations, but users can change them and see their results. That's what we are not necessarily, we give this tool to people to use whatever fits best for their situations and then see the results. And prevention measures are things that we want to implement next and see, for example, if we move around the stuff, what would be happening in the situation if we change the schedule. That is one of the common measures that people are doing in these situations. What would happen, cohorting, etc. These are the things that we, now that we have this base model, we are hoping to work on them and do some, get some more results out of this. And with that, I conclude. Sorry, I hope I have finished and time to give our participants to ask critical questions for us. But I stop here. Thank you so much.
Thank you so much, Professor Asgary, for the great talk. It was quite interesting. Dr. Rufo, do you have some questions there?
Yes, hi. Thank you so much for the talk. Yes, so we have a question by Dr. Furman. So please ask. Thank you.
Yeah. So thank you very much for the nice talk. This is Jan. Could you please go back to the slide where you explain how the contact rate or the contact times are calculated?
Sure. So I have to probably share my screen again. And before you go, I should say that we have some of our team members here also that can answer questions.
Mm-hmm. No, that was not the slide I meant. I think it was 2 slides before.
Thank you very much. Go ahead, please. Okay.
Sorry. I think, yes, this one. So here in the 3rd row, the contact with yellow person number 1. Their times are not added up. So in the last column there, this 1, is it just a typo or is there anything special here that I did miss?
Mohammed, can you, because that is what you know better than me on that particular case. I can start with a few.
Hi everyone. The question is why we have a number 1 in the last row?
No, in the 3rd one. This one. I think that is it?
No, the one above. Where you have 1, 1, 1, and 1.
This one?
Yeah. So
we have an array that stores one of the component contact number, another component for the contact time, and the time. 3 components this matrix for everyone has. So the number 1 yellow person is inside the circle at the time t, and in time t plus 1 it goes out. So at time t we have 1 contact, 1 second, and the next time this is not changing because he or she left this area, and we have only 1 contact and 1 second contact time. So we don't change these values in the array.
Oh, okay.
And for others, you can see what happens. For example, the 1 blue is inside the circle at time t, and in time t plus 1 it doesn't leave. So the number of the time of contact is increased to 2, but we assume that it is the same contact, so we don't change the number of contact for this guy.
Yeah, so okay, now I got it. So both contact number and time are accumulated. I see. Yeah, thank you very much.
Thank you.
Thank you for the answer. Thank you for your question. Also, Rufo, do we have another question there?
Yeah, so we have another question from Sanjay. So please, you can ask your question yourself. Thank
you. So just as a bit of background, I also work in a kidney unit in London, Ontario. I also make mathematical models. Thank you for the lucid presentation. I think you have answered my first question quite nicely in how would you go about generalizing the system. The second question I have rather is, I have now promptly forgotten that question, so I should look it up. Oh yes, so I remember now. So the question comes to mind is that the dialysis units by definition are open systems. And so how would you sort of have a term of some description that accounts for this openness of the system? You have marginally sort of hinted that you will incorporate stochasticity in the future. But other than that, are there any mechanistic terms that you can add to the model that will bring it that much closer to reality?
You mean if we have, if I understood this correctly, in terms of the open, in terms of the setting, yes, it captures in this way that at least from, for example, these cases where you see when we calculate 2-meter distance, it does not recognize the walls among the unit, the stations, because there's no real walls there, they're just curtains. So that doesn't capture that, you know, or doesn't consider those curtains as, but probably this is not your question from what I understood from the second part of your question, or was it?
What concerns me is that whatever unit you're considering, the dialysis unit, whatever, there are people coming in and going out.
Yes.
Stuff coming in and going out, all of which have contact and everything else with people or components that you may not have accounted for. Have accounted.
Okay. Open system from that. Yes. Okay. Yes. You are right. Well, from what I know, and you know certainly better than us, and from what we heard, we are not able or allowed to go there, but we were told that under the current conditions, it's not open system anymore, or open to everybody. So it is basically closed to for example, patients and visitors, etc. Is that the case there?
So I'm sure your experience of a hospital setting is more extensive than mine. But how predictable is the behavior of your nurses, nephrologists, and perhaps even patients?
This is absolutely right, and very good comment, and in fact observation. That is correct. What we are capturing is what is meant to be the process or protocols that they follow. But obviously, for example, a nurse may come half a way in a real situation and go back and do something else and come. And yeah, there are those kind of things that we haven't. I mean, we can say we can get closer to that if we add some additional, for example, elements of those nature, as we, you know, can, if you, for example, provide us that, yes, in addition to these kind of things, this may happen also, we can add this to this model. But whether that is happening in every situation or every time, that is something different, really. Yes, but I really understand what the point is. We cannot definitely capture every detail that is happening there.
Thank you.
Thank you.
Thank you. Dr. Arufo, do you have another question there?
Sorry. I don't see any other question in the chat. So if you want to ask your question in person, just let us know. Maybe you can raise your hand on Zoom, and you can ask your questions. In the meantime, I have one.
Okay.
Ali, again, thank you for the presentation. So I probably missed that if you said that, but have you considered somehow the susceptibility of getting infected of the patients? Like if they're more susceptible somehow compared to the nurses? Their susceptibility, not in this way, but they are just like other people coming to the system. Their susceptibility, I mean, outside the system is, you know, obviously because of the other contacts that they have, especially through transportation systems and so on. But we really, no, we don't check for that. For our simulation, for example, runs, we just assume that there is one person coming into the system as an infectious person, but susceptibility in that sense it's mostly, you know, just like others. I don't think we are treating a special or a special case for them, for the patients. Oh, okay. So you're just treating the nurses and the patients as their own unit, right? So you're not considering, for example, that nurses might have, you know, going to different floors, which might be maybe a more risk
how to say, environment, and so they're more susceptible to catch the environment. To catch the virus. So there's not different in the susceptibility in the
not really.
among the agents.
That's exactly what I think I mentioned, that this really the transmission probability may differ between these and among different agents, exactly, and that is what we don't have the numbers for. But yes, this is something that taken into consideration. They have at least different transmission probabilities, and the way that they work there, and even that's why the next step even for us do this is check for example the impacts of all the PPEs, etc. on this, how it works.
Perfect, thank you.
Thank you for the question.
Dr. Asgary, as you look forward to looking at the impact, as you just mentioned, of PPEs, which I will assume you will take into account some non-pharmaceutical interventions. I'm just curious to know about if there could be, based on what you have seen in the literature, differences among provinces. For instance, when it came to nursing home, we realized that some provinces put in some protocols that were able to protect the number of cases they had in nursing home. And then look at these dialysis units. Is there differences among provinces within the country based on the protocols?
I don't have details on that. I don't know if anyone in the group here has details on that, but usually these are, for example, networks by network, they have their own protocols. It may even vary even inside the province. Different health network, they may have their own protocols, but often, they use higher level protocols that come to them. And for example, I've seen in our, a review of these materials, etc., that, some still use, for example, what CDC is telling or providing. It's it varies, but not too much. Most of them are quite, things that every I think unit is doing. And in our case, what we did was we went through a list of existing protocols and just asked this particular unit, for example, which of these protocols are you implementing? For the most part, they are quite similar to, for example, practices in other countries.
So we will expect in that case, the ratio of number of cases in any dialysis unit to be the same. The ratio to the population, for instance, if we were to look at Alberta and we look at Ontario, based on that, we expect that the ratio of number of cases will be the same because the protocol is the same, and whatever they put in place when COVID started should have been the same. Is that correct?
That's a good observation, and actually, I think I should take a look at those differences also. But I think much of it also relates to what happens outside the hospital and those differences. For example, in communities where you have, I mean, mostly, of course, these patients are of those that are, vulnerable in many different ways, especially socioeconomic status, etc. And they, depending on which community they belong to and go to, they may be more exposed and impacted, unfortunately. And this varies also among different provinces, large population centers versus smaller population centers.
Thank you. And you don't have an idea as of now as the number of cases that result through contact tracing, the number of cases that may have resolved as a result of somebody visiting a dialysis unit. Do you have an idea as to the number of cases that may come out of that?
I don't have that, no, sorry. I don't know if anyone from the group knows that, but no, I haven't. But that's good to know, really, yeah.
Thank you so much. And thanks for the great talk. Very, very helpful and very useful. And may I remind our audience that the ADISM Research Institute has come up with an application that will help in drive-through vaccination clinics as we come up with a vaccine and start our vaccination. Thank you for the great job, and thank you for what you're doing. We are proud of you, proud the whole country is proud of what you're doing. And we are glad that you came up with such an app.
Thank you very much for having me and the group in your great discussion series. And I really enjoyed those, and wish you all the best for the rest of the year and year to come.
Thank you so much. And to our audience, please, thank you for visiting us. Thank you for being a friend of the Canadian Center for Disease Modeling. We do have this every other week, and we look forward to seeing you here in 2 weeks. We will be having a great speaker in 2 weeks. Thank you so much. Again, please do follow CDM on Twitter. Check our website. I think our Twitter handler is there at York_CDM. Thank you so much for joining us, and have a blessed day.
Thank you very much.
Thank you. Thank you so much, Ali. Thank you. Amazing presentation. Thank you. Have a good day.
You too. Thank you. Bye-bye.
Bye-bye.
Bye.